My name is Santosh. I was a CME here in ICU. Now I am doing an educator role. So mostly I was teaching students many critical skills like bag work, resistors, mechanical ventilator, BVM, then other NIV and all those things. Have you learned about NIV and other things? Not yet. Okay. So in ICU, if you are looking at ICU, you can see that oxygenation is the most important thing we can think about ICU. If patient is hypoxic, we can use many things. As you have learned before, oxygen therapy is very important in ICU. We can use many devices. Can you say some of the devices we can use to give oxygen to the patient? Nasal pumps. Hudson mask.
CPAP?
Yes, CPAP.
High flow?
High flow. Venturi mask.
Is Venturi rebreather the same?
No.
No.
Venturi mask is just giving bit of air, is projecting to the patient, so he's getting bit of PEEP also, bit of oxygen pushing into the patient. Non-rebreathe mask is, it has got a reservoir, so the patient is getting 100% oxygen. When they breathe, oxygen is less means patient is getting 100% oxygen, because whatever he's getting, in a normal scenario, Hudson mask, what is happening? If you are giving 5 liters of oxygen, how much patient is getting? 5 liters of oxygen makes only 28% of oxygen. Yeah? Rest, patient need 100%. If they are breathing 100%, what is rest? Rest is the atmosphere. Yeah, nitrogen, carbon dioxide, other gases. Yeah? But if patient has got a non-rebreathe mask, it is filled with what? Oxygen. What our patient is breathing in, full oxygen. Around 90-95% patient is getting oxygen. That is non-rebreathe mask. Sorry. Venturi mask is, we can dial up. We got red, green, blue and all those colors. So if you dialing up, we can change the percentage. If you are dialing up white, it is certain percentage. Red, certain percentage. We get different one. Coming back to nasal pumps. Nasal pumps up to 4 liters of oxygen you can give. Yeah, you can't give more than that. You are putting the prongs on the nose and you can dial up to 4 liters of oxygen. So it is around 28% of oxygen patient is getting. If you need more than that, we will go to Hudson mask. Hudson mask, how much you can go up to 10 liters, there is no problem. But what is the minimum? Minimum is 5 liters. Why minimum is 5 liters? Because patient is breathing out what? Carbon dioxide. If there is not enough flow, what will happen? The carbon dioxide will remain in the mask. They will breathe that back again. So what is patient is breathing back? Carbon dioxide. Then what will happen? Blood, carbon dioxide in the blood will go up, isn't it? So if we have 5 to 6 liters oxygen flow in the mask, what will happen? It will flush out all the carbon dioxide which is breathing out by the patient. You got the point? So what's minimum? 5 liters. For nasal pumps, what's maximum? It's 4 liters. Yeah. Then Venturi mask, we already spoke about Venturi mask. We need to talk about non-rebreathe mask. So we need to connect to the oxygen flow meter. You have seen the oxygen flow meter, isn't it? Dial up how much? 15 liter all the way. That is the maximum, 100%. That will fill the bag here. I don't have one here now at the moment, but I can show you later. That is non-rebreathe mask. If patient is failing that, what we will go for high flow, isn't it? High flow nasal prongs. High flow nasal prongs, The other nasal bronchs we can give only 4 liters. This one we can go up more than that. We can go up to 60%. High flow is oxygen is coming through a humidifier. Okay, humidifier is what? Humidifier is giving bit of warm and moisture to the oxygen. It is mixing with heat and moisture. When you are giving nasal bronchs, normal nasal bronchs, what is happening? We are giving dry oxygen, isn't it? It is not humidified. How the oxygen is transported from there, one place to other place?
Just one wire.
Yeah, it is only one wire when you are giving the nasal bronchs. But it is not humidified. When you are breathing in, what is happening? Our body temperature will heat the oxygen. Body will moist the oxygen, isn't it? But when you give nasal bronchs, it is not happening. What's the consequence for that? Dryness. Patient will get dry mucus. It can form sputum plug in the lungs. Patient will get lung collapse. If the sputum plug is sitting in the main branches, that part is gone. Patient will get lung collapse. So we need to humidify the oxygen. How we can humidify? We got a machine there that will give a bit of heat and moisture. We put water there, so it will give a bit of moisture. That will help the patient to get rid of all the sputum and everything. Okay? That is called what? High flow nasal bronchs. In high flow nasal bronchs, what we can do? We can go up to 80%, 90%. Excuse me. There is no problem of giving oxygen. We can get PEEP also. What is PEEP? It is too much for you. I know sometimes it is too much for you. PEEP is what? Positive end expiratory pressure. Okay? This is a good wording, positive end expiratory pressure. PEEP. Yeah? Okay, what is happening with just imagine this is your alveoli. Yeah, okay? Small alveoli. This is another alveoli. Okay? So what is happening? Air is entering. Okay? Then capillary beds are going there. The circulation is here. Blood is going there. So when air comes in, oxygen is going into the bloodstream, carbon dioxide is going out. You know that already, isn't it? Yeah. But if it is not inflating, the surface area will be less. Because see, only touching here, it is touching this much. So it needs to get inflated. PEEP actually doing what? At the end of the expiration, because if you are thinking about a balloon, you got a balloon there. When it is hard to blow, initial or middle or last? Initially. Why? Because it is sticking together. So if you blow little bit air, it's easy to blow, isn't it? So after the expiration, if the alveoli is collapsing, what happens? It is very hard to blow again. The PEEP is doing, leaving little bit of pressure there, little bit open there. That's benefit for next breath. If it is little bit open, what's happening with the next breath? Easy to blow. So it will avoid lung collapse. PEEP is positive end expiratory pressure that will avoid lung collapse. Then we come to CPAP and BiPAP. CPAP is we are putting a mask and using a machine, and we got a PEEP and pressure support. We push the air, positive pressure to the patient's lung, and it will get inflate. That is CPAP or BiPAP. We call it non-invasive ventilation. Invasive means next stage. We put a tube in the throat, that is in the trachea, and we connect to ventilator, and we will develop 600 ml of volume push into the patient's lungs. Ventilator will push that in each minute. Okay, that is mechanical ventilation. So nasal bronchs, asthma, so these things comes now mechanical ventilator. This is another important thing you need to learn in your nursing career, I should say. Because this is going to be mandatory for all the nurses. This is another oxygen device. What is it? Bag valve resuscitator. Yeah. Have you used this before?
Only on the tummy.
Only on the number. Okay. Okay. This is going to be mandatory for all the people to get assessed. Doesn't matter if you're working in ICU, what doesn't matter. So this is very important. As a student, this is a good time to learn. Okay. This bag valve ventilation comes in different sizes. So let's go through this. Bag valve BVM is adult 1600 ml. This is 1600 ml. Children 750, neonatal 450. Okay. What are the indication? Indication if they have hypercapnic. What is this hypercapnic respiratory failure? What is hypercapnia?
Carbon dioxide.
Carbon dioxide. Very good. If the carbon dioxide is high, we call the status that hypercapnic. Yeah, means carbon dioxide is high. What's the normal carbon dioxide?
Percentage.
Yeah. What's the number in ABG? What's the normal? 35 to 45. Yeah.
That's good.
All right. Hypoxic respiratory failure. If their oxygen is less, what we can use? You can use this. Apnea. If they are not breathing. Okay. Some people don't breathe. What condition? Maybe their brain is gone. Respiratory depression due to GCS, reduced GCS, or if they get a lot of sedation, you push some propofol. What will happen? It will depress the respiratory center. Then patient won't breathe. Then we can use this. It will, and we can push air to the lung. Once they get the oxygen, once they get rid of the carbon dioxide, they will start breathing. Anesthesia, we already mentioned that. Contraindication, complete upper airway obstruction. If they have an upper airway obstruction, if they choked some meat, it is there. We can't use this. Then what we can use? Yes, very good. Tracheostomy. Tracheostomy. What do you call it? Call this one? Opening here. We make a stoma there. What does it call? Tracheostomy. Alright. So we need to do a tracheostomy. We make a hole here and we can connect the oxygen there like this. Okay? Then still we can pump. Alright. That is that. What are the things you need? A BVM, oxygen source. We need to connect this part to the oxygen tubings as a PEEP valve. This is the PEEP valve. Okay. Simple airway adjuncents such as an oropharyngeal airway and nasopharyngeal airway. Okay. Oropharyngeal airway and nasopharyngeal airway. Have you seen this before?
Yeah.
Yes. Which one is nasopharyngeal and which one is oropharyngeal? Yeah. This is nasopharyngeal. Yeah. So there is a technique to put that we will come and see in a minute. In general, by BVM is with the 2-person technique. Okay, one person is holding the mask, other person is bagging. Yeah. You need to have PPE because what will happen when you're bagging? Sometimes patient secretion can spill on your face. Okay. So to avoid that, PPE place patient in a supine position. What is supine position? This position, not side position or anything. The appropriate held tilt chin lift maneuver or a jaw thrust help keep the airway open, and oropharyngeal airway may inserted, a nasopharyngeal airway can be inserted. Okay. All right. So, do you know what is head tilt chin lift maneuver? So these things, it is very important you need to learn. I'm telling you, these are the basics of nursing, really. So if you are missing that in uni, you need to learn in clinical area. Okay, let's do here. Okay, we want to show the head tilt chin lift maneuver. You can come, any of you. Do you know what is head tilt chin lift maneuver?
Is that the same like CPR? When you get the- is that the
Yeah.
same?
Yeah, but I just wanted to ask you, what is head tilt chin lift? Head tilt chin lift, that's it. This is head tilt chin lift maneuver. What is the benefit of this? If patient is blocking his airway with the tongue, yeah, it will unblock the airway. Okay, then what will happen? Patient can breathe easily. And if you are looking at the airway, it is just a horizontal line. So if you are doing a BVM in this position, very easy to go the air inside. There is no problem getting air into this patient in this position. Okay, this way, yeah. And we are seeing that jaw thrust. This patient is having a spinal cord injury, C-spine, cervical spine fracture. If you do this, what will happen? Patient will die soon. Why? Patient has got a spinal cord injury. So if when you are doing this, it will king the spinal cord and patient will die because it is not communicating with the heart rate and everything. So it will, what will happen? Patient will die if you are doing this. So if you have a fall here, patient is not breathing, can you do this? No, because there is a suspected spinal cord injury. So you can do this. Then what we will do? Which measure? We can use this. Which one? Jaw thrust. How do you do jaw thrust? Put hands on the cheek and pull this one up. Without doing this, what we are doing? We are just doing this. Pull this one up. Then what is happening? The same thing. The line will be up and the blockage will go. How do you do? Just push the jaw up this way. Okay? One person is going to do this, then other person is going to bag the patient. We'll do that in a second. But before that, I just wanted to ask you, how do you put this? This is called oropharyngeal airway. When you're putting a oropharyngeal airway, there are different sizes oropharyngeal airways. Doesn't matter if you work in a ward setting or here, you need to know how to measure that. How do you measure this? This is incisor, the middle of the tooth is incisor. Yeah? From the incisor to the angle of the jaw is the measurement. If you are putting, how you are putting this? This way. It is sitting in this way. Yeah? So incisor to the angle of the jaw. But with mannequin it is very hard to measure. But with the human it is easy to measure. From incisor to angle of the jaw, if you are thinking that it is sitting there, it is the size of the patient. We can use that. How you put this? The old method is that you are putting upside down first, pushing inside. Yeah. When this part is touching the palate, the upper mouth, you turn this one to the normal position, then just push this one inside. Why we are doing this? If you are putting this one in this position, what will happen?
It will push the tongue.
Yes, it will push the tongue down and it will block the tongue. Okay, we can't do that. Alright. So that is why what we are doing, we are just doing this then turn it around and push it down. You want to do?
This way first.
The other way, yeah. Yeah, we covered the tongue, now turn it the other way, push it down, that's it. Okay, you want to do it again? Yeah. Very good, you want to do? Come, everyone do.
So it's like.
Yeah, halfway, the tongue is over now, turn it round, push it down. Very good. You want to do? Come. Yes. So if you get a cardiac arrest or med call in the ward, what you need to do? You can do this. Okay? You check doctor's ABC. Danger, response, send for help, then airway breathing circulation. When you are doing airway breathing circulation, when you do breathing, you can do this. Okay, somebody is doing the CPR, you can do. I mean, no one will ask you why you did this. This is very important. I am telling you that this is very important. You can just quickly put this, then you can bag the patient. Okay, the patient will get some oxygen. Before, how they were giving the oxygen, I mean breathing, they were breathing, they use the pocket mask and blow. They blow, somebody will blow patient's mouth with the pocket mask. Have you seen pocket mask here in the hospital? No. Pocket mask is a very dirty method of giving oxygen because COVID patients are there, flu patients are there. Just imagine if you are blowing, who is going to blow? I am not going to blow if it is a COVID patient, putting the mask down and blowing. No. In that situation, what? This is very useful. That's why they are making it mandatory for everyone. Okay? Okay, that is there. Then what is the next one? Is nasopharyngeal airway. This is also very important. This we can't put if patient has got a gag reflex or if you have some trouble, don't put this one. You can put this one. You don't have to put both, but you can put either this or this. This is called nasopharyngeal airway. You are allowed to put this one. Okay, how do you measure this one? From the tip of the nose until the terminus of the ear. This is the terminus of the ear. Okay, so you measure this one. This is right. Then put some lubricant. I don't know. So put some lubrication. Then you push it down. When you're pushing down, the cut face should be facing outside. So if you have lubrication, it will go very easily. I don't have lubrication. Otherwise, put it in patient's mouth. So get some lubrication. Push it. Yeah, anyway. All right. Have you got any hand gel here? Yes, maybe that will work. Okay, how do you put? You can try. This is mannequin, so you don't have to worry.
So this is
Cutting
facing
face
us.
outside, yeah. Yes, that's it. Yeah, the measurement is bit weak for the patient. Yeah, you want to try? I want you to do this when there is a cardiac arrest. Don't step back.
So facing outwards.
Yeah, push it up. That's it. It won't go anywhere unless patient got a base of skull fracture. If patient got a very bad accident, they got a head injury. If you are suspecting patient has got a base of skull fracture, when you're putting that, it can go to the brain. Otherwise, it won't go anywhere. You can put easily. Don't worry. Okay. Put some lubrication. If patient is having cardiac arrest, patient is already dead. what else can kill the patient? Nothing. Yeah. So these things are easy, isn't it? Do you think it's easy? It's not complicated. No one is going to ask you why you did this. Okay? You need to do this. And this is other thing. Then now we are going to see this part. Then we done. 1% technique that is not allowed in that is allowed in the hospital, but preferably 2% technique. So we will see that. This is a 1% technique. You hold the hand C and E. That's it. This is E. This is C. Yeah. Two-person technique. We'll see 2% technique. That's all. So what do? This you connect to where? The oxygen. 15 liters oxygen you put it. Yeah. Then what do? Then the bag will get inflated. This is a reservoir bag. This will get inflated. Okay. Then when you put it, this sharp end goes to the nose. All right. Then what do? You hold the mask. E, C. E is this, C is this. So E, C. Hold firmly. So head tilt, chin lift. Yeah. Then what is going to happen? You bag the patient. This is around 1600 liters, mLs. You don't have to push all the way, but you can push half. Good half. Yeah? Yeah. So if you are seeing this, you can do this. See, the chest is rising and falling. Can you see? Yeah. So if you have 2%, it's very easy. So people, somebody is doing CPR there. How much CPR they are doing? They are doing CPR 30 is to 2. 30 is to 2. 30 compression, 2 breaths. Once, either if you don't have many people there, what you can do basically, you got a CPR person is there, 25, 26, 27, 28, 29, 30. Then he can come and push 2. 1, 2. Then he go back there. 1, 2, 3, 4, 5. Again 34, 25, 26, 27, 28, 29, 30. 1, 2. Then again he go there and do. If you have enough people, what do? You just hold this one like this nicely. Other person back. Alright? So, do you want to do that? Put this one and do. Yeah, yeah, you can do. Yeah, you learned. Very good. Yes. That's okay. It's a good one. That's why that's got a
The same.
sense.
Okay.
Yeah.
So 2 breaths. Right?
2.
Okay.
30 compression. 1, 2, 3, 4, 5, 6, 7, 25, 26, 27. No.
Oh, sorry.
When you're doing 25, 26, 27, 28, 29, 30.
And then 2.
1, 2. Okay, again. 25, 26, 27, 28, 29, 30. Very good. Switch it off. Your holding was very good. Normally, people who hold first will not have this much seal. Yeah.
So 30.
Yeah, 25, 30. Very good. And you guys are doing good.
30.
Yeah. 1, 2. You can count. 1, 2. Yeah. If patient is intubated, we don't have this mask. We got a tube there. Then you connect to the tube. Then you just in a minute 10 times. They will not stop the CPR for this. You just continue this one. 1, 2.
If they're intubated, they don't.
They don't stop. Yeah, they just continue this. We just continue this. We don't stop.
You said every 10 breaths, right?
No,
I mean, every 10 compressions and then a breath for each.
no. if patient is intubated, you give 10 breaths in a minute.
Oh,
In a minute. They give whatever they are doing. So how much they need to give? 100 to 120 compressions per minute. They will continue that. We don't look that, they don't look this. We continue this. 10, aiming for 10 breaths per minute. Yeah?
So it happens at the same time.
Same time. Yeah. If it is not intubated, we stop for breaths. Why? Because this is mask. If you are doing compression, the air will not go inside. But if you have a secured airway, what will happen? It is in trachea and it has got a balloon and it has got a sealed area. If you are pushing air, regardless if you are doing CPR or not, the air will go into the lungs. That's why intubated patient, you don't stop compressions for breaths. You just continue aiming for 10 breaths, more than 10 breaths per minute. You just do this. One, very easy job when there is a cardiac arrest. You just do this. And the person, one who is there, they will continue the CPR. And that is a big topic, CPR, ALS, BLS, we won't talk about those things. Do you want to do this?
This kind of
Yeah. So you connected to 15 liters, yes. Yeah, we can put this one in the side because person who is doing the compression there. Okay, better. Yeah, I think maybe we can just move this one a little bit up. Okay, okay, 25, 26, 27, 28, 29, 30. Yeah, yeah, good. But you can improve a little bit more. Okay, yeah, good. Okay, one, two, very good. You can switch around. One, two, very good. 25, 26, 27, 28, 29, 30. 1, 2. See, when it is making the noise, that means the maximum volume is reached. Yeah. That's good. But little bit air, even if it is little bit air going out, what will happen? Before I told you, we were blowing in the mouth. What we are blowing actually? We are breathing in 21%. We breathe in and we are blowing out. What we are basically blowing in? Carbon dioxide plus little bit of oxygen. But even your technique is not that great with this oxygenation. Patient is going to get maybe at least 50%, isn't it? If you are blowing, not even 21%, patient is getting. So that's why this is very important. Patient is going to get benefit from get some benefit from this. Plus, you are not having contact with any communicable disease. Okay. Other thing is that when you are using this, the ICU come, they will take over. But until then, you can do this technique of giving oxygen. So what is doctor's ABC? You know that when somebody is doing this, you open this. It is in the emergency trolley. You can start using that. But you need to get assessed for this. Your CNE will get assess you for this. Then you can start using this piece of equipment. And after each patient, you just discard this because this is one person. It's a disposable item. After each patient, you need to change. One more thing I just wanted to say. If this intubated patient, I told you, this is sealed area. If you're pushing air, where it will go? It will go directly into the lungs. what happens if you push too much air? Patient will get barotrauma. What is barotrauma? They can get injury in the lungs. So intubated patient, maybe you need to be conscious how much you are pushing the air. This is how much? 1,600 ml. How much? 100. How much volume a person will need? 5 to 7 ml per kg body weight. If it is a 100 kilogram patient, how much they will need? 500 to 700, because per kg 5 to 7 ml. This is 1,600, and you can have the option to give 1,600. So how much you need to give? Maybe 500 to 700. So if it is especially if it's intubated patient, maybe you will need, you can hold in this way, so you won't miss that. Okay, how much you need to give? Maybe this much. If it is intubated patient. If it is not intubated, maybe you can push a bit more harder, because you are going to lose a little bit of air here and there. That's okay. But do not over-inflate the patient's lungs. If you are doing BVM, what is the other thing? The patient can get aspiration pneumonia. How they are going to get aspiration pneumonia? Because this air, patient is not having a secured airway. So where the airway, rest of the air will go? Some will go into the lungs, some will go outside, some will go where? Stomach, isn't it? It's the two pipes are close together. So some air will go into abdomen. So they can get gastric distension. That gastric distension, help me. That gastric distension will cause what? They can get aspiration pneumonia, because when they have the burp, all the gastric contents can come out and it will go into their lungs. That is why it is very important to have a NG tube when we are doing this. So later, after patient is surveyed, normally they will put a NG tube to avoid patient getting aspiration pneumonia. I think that's all today, because it was a rushing lot of information. Do not patient. If you are doing this, I was talking to girls before. Sorry, I don't know your name. I forgot your name. Coached is a continuous compression oxygen away. So somebody is doing this CPR, then they come with defibrillation. Okay, before they do defibrillation, when they operate the defibrillator, they will say continue compression. The person who is doing the compression, they will continue oxygen away. This is oxygen. They will take the oxygen away like this. Why? Because the free flowing oxygen is there 100%. If you are putting the oxygen like this, what will happen? When they defibrillate, when they shock the patient, there is a fire risk, because oxygen is more prone to get fire, isn't it? Yeah, they are shocking the patient. That time, if the free flowing oxygen is there, there is a fire risk. So oxygen away, you need to do this. That is another tip you need to know. Okay, if there is, you will do that. Yeah, oxygen away, then you need to do that. Okay, once they defibrillate, you come back and do this. Okay. I think that's it. Do you want to ask anything? Nothing? Good. I am confident in using this. If somebody is going to assess you tomorrow, you'll be all right. Yes. Okay. What is the main thing you learned from this?
You need a clear airway.
Clear airway. Yes. Yes. That is very important. Clear airway. So we check already airway breathing circulation. That time we check if there is any secretion. What do? You do suction before using this. Yeah. Clear airway, and it is a very useful piece of equipment, and you will be get assessed when you come for work as a RN. and it can be used for any patients. Whatever the indication we have seen, we can use that. If it is a cardiac arrest, unconscious patient, they cannot breathe by themselves. If carbon dioxide is high, we can use it. Yeah. All right. If you don't have any other questions, thank you.
Yeah, thank you. Just read this.
Yeah.
Thank you.
Maybe you can just hold this one. Okay. You guys are afternoon? Okay, thank you. Alright, see you later. Oh, I forgot to. Thank you.